Good evening. I'm Kathy Wareeye, CEO of Infection Prevention Partners, and I would like to welcome you to this evening's symposium. Nanosonics is your sponsor and host for this evening, and the topic is ultrasound use and reprocessing. And we're going to do a couple of things. We're going to share a snapshot of current practice based on a recent research study, and we're also going to launch a toolkit for infection preventionists on ultrasound probe reprocessing. So we know that that ultrasound in our institutions over the last couple of decades has been nothing less than explosive. Volume is high and getting higher, and it seems like every day there's a new procedure or therapy that involves ultrasound use. And so I can imagine that for an infection preventionist, getting your arms around all the places where it's being performed and all the people who are performing it and ensuring that your patients are not at risk could seem like a monumental task. But help is on the way. We have with us 3 experts this evening. I'm going to introduce them now, and then we have a couple of housekeeping items after that. So to my right is Roy Boukidjian. I'm going to read these bios to you because our experts have such deep experience. I don't want to miss any of that detail. So Roy Boukidjian is System Director of Infection Prevention at Dignity Health in San Francisco. He currently serves on the California Department of Public Health HAI Advisory Committee, Partnership for Quality Care and Hospital Quality Institute Infection Prevention Work Group, and that's the main arm for the California Hospital Association. Roy has partnered with the Centers for Medicare and Medicaid Services by co-chairing focus groups for the reduction of C. difficile and CAUTI and presenting in various venues. His work has been cultivated by being awarded the national recognition of Heroes of Infection Prevention by APIC in 2013 and 2017, respectively. Twice. Good. Roy will discuss guidelines on ultrasound use and reprocessing and our recent research study on ultrasound-guided procedures, some of which have led to outbreaks. The non-trivial challenges faced by the infection prevention community will also be explored in the results of the research.
Hi, everybody. So full disclosure, today in the morning, of course, I forgot to take some medication for upper gastric pain, so my stomach's on fire, but the even funnier point, I was talking to a colleague here tonight, and I sat on a chair and the chair was wet. So now I have a cool bottom and a fiery upper gastric area, so there's... We'll deal with it. We'll deal with it. You gotta love it.
It is too funny.
Okay, all right. So let's start off with just giving you an overarching view of ultrasound in relation to us. So we know managing ultrasound probes in relation to infection prevention is a very challenging task. It is really, really challenging. And because of that, a group of IPs historically, about maybe a year plus ago, came together to work and develop an IP toolkit that would assist in mitigating those challenges altogether. So in this particular talk, we'll define some of these challenges, but my colleague will go over the toolkit specifically after this section is over. Okay, so briefly, what is ultrasound? We know ultrasound probes are heat-sensitive, reusable medical devices. They are used to visualize the anatomy in a variety of procedures. These probes could require low-level disinfection, high-level sterilization, and it really depends on the contact site, and that's key. So just keep that in mind of where that probe is, and that'll lead you down the right path. There are typically 2 types of categories of ultrasound probes. We have, of course, endocavity, and we have the external surface probes. And, of course, they come in various shapes and sizes. Okay. On top of all that, it is super complex. And the reason why it's super complex is because ultrasound probes are used by multiple people, in multiple places, and in multiple procedures. So you put all those variables together, and you could see how complex this can get. And we always refer back to the Spalding classification. So, obviously, if we are scanning intact skin surface area, then it is considered low-level disinfection or non-critical. If you're using it and have contact with mucous membranes, then it is high-level disinfected, semi-critical. And if it's touching sterile tissue or the vascular system, then it is considered critical, and therefore sterilization would be required. Now, CDC has addressed this in the past, in which they do call out that if sterilization cannot be achieved, that high-level disinfection is appropriate as long as it is used with a sterile sheath. Okay, so it's a combo in lieu of sterilization. In addition to all that, Joint Commission released a safety alert in 2017, basically detailing how sucky we are in managing ultrasound probes and actually disinfecting them appropriately. 74% of all immediate threats to life were from improper sterilization or high-level disinfection of these particular devices, and data showed non-compliance that has increased from 2009 to 2016. And it's not that because we did a better job in 2009, it's because we are more focused on them now. So obviously the more focus you have, the more you're gonna find. It's like peeling an onion. So we also wanted to pull some real-life frontline examples. So this particular individual actually responded and posted to the AORN website, and we just zoomed in on a particular piece in which this individual claimed that this past January they had Joint Commission. They were cited on how they decontaminated the ultrasound probe utilized solely for nerve block patients in the perioperative area. Now, my understanding that there was a previous discussion, I believe yesterday and I believe today, about nerve blocks and ultrasound probes. But again, it all comes back to the contact site, and we'll go into it a little bit further. But basically, Joint Commission told these folks that unless they stopped all blocks because of what they were doing, that they were going to get an immediate threat to life. And that is their new term, threat to life. So everyone's like, oh my God, forget immediate jeopardy. No, 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 threat to life. More impact. Okay. So this particular slide, when I looked at it, and the screen was 2 inches in front of me, I couldn't even read those 71 procedures. So if you could tell me what number 40 is, that'd be great. But the takeaway from the slide is that there are over 70 plus ultrasound probe procedures done, minimum, and that a significant portion of these require high-level disinfection sterilization because of how they are used. And here's a prime example. So contact with the site is one of the main key criteria to define how these probes should be cleaned. Now, it's not only the procedure, but it's the user as well. So some users claim that, you know what, my probe, when I utilize it, it is 2-3 inches away from the puncture site. And therefore, low-level risk, intact skin, non-broken skin, I'm good. I'll wipe it down. I'm good. And some actually have the probe right over the puncture site, and that changes its classification. So it's not only the procedure, but it's the user themselves. So, as we go through the discussion today, and when you go back to your facilities, and if you have an opportunity to actually venture out and see how these probes are used, it's not only where they're used, but how they're used and by who. Because, for instance, one interventional radiologist might use a probe very differently than his colleague, and that'll change it altogether. And again, the more complexity it gets. Okay, so we know outbreaks have occurred with contaminated ultrasound gel. We've heard and read about it multiple times. But just to give you a different field of view, it is easy to trace, not easy, but it's more likely to trace outbreaks to a common source. Product, probe, ERCP, CRA. If you hone it down to one particular aspect, it's pretty clear. But when you use ultrasound probes like we do today, left and right, you got 2 infections here, 1 infection there, it's very hard to trace back to a particular improper practice that's going on, or just improper disinfection and sterilization altogether. So there is that window that might basically give you a sense of a much larger problem than we originally thought. Okay, so again, as we know, ultrasound probe covers do not replace high-level disinfection. We know that. But to supplement that, a survey found that 25% of interventional radiologists had experienced a needle stick injury in the past year. So why does that matter to us? Who cares? Okay. Well, think about it this way. if I injured myself 25% of the time, I'm probably injuring the other arm that's holding the probe that has a cover on it. So the likelihood of puncture of that sheath is more likely than we would assume. You know, it's, well, yeah, if it's punctured, we remove it, replace it, how does it affect, et cetera. But truly, the big question mark is if you're puncturing yourself 25% of the time, how often are you puncturing your so-called sterile sheath, okay? And 75% of the cases were attributed to operator error. Oh, and one other thing I just want to cover, going back, if I can go back. And this is just, you know, clear cut, and some would say, yeah, we already know this, but I just want to hone it in, that even though we use a sterile sheath, that doesn't mean we could just wipe down a probe with a disinfectant wipe if it's used in a semi-critical state, right? We all know this, but from time to time we get the answer from a radiologist, oh, well, you know, I just wipe it down. What are you talking about? There's a sheath and I have rubber bands. You see my rubber bands? I'm like, yeah, I see your rubber bands. Thanks. So here's another visual of complexity. You know, even though intracavity probes are on our radar, however, surface probes, they're much more complex because they're used by more departments in a variety of procedures. They are disinfected differently. One of the facilities that I had an opportunity to talk to, they process their probes one way, and the Women's Center processes them one way, and their oncology one way, and their OB one way, and their ED one way. It's like, what about standardization? What's wrong with you? And he is a good friend of mine. And truly, they don't feel that they have direct oversight over these departments. This is my department. I know I'm doing it right. I don't know what they're doing. So, you know, good luck. And that just adds another level of complexity. So a national survey that was actually conducted recently by our colleague, Ruth Carrico, and I believe she will present the exact survey results at this conference on Friday, right there at 9:30 a.m. at room 200. But we just wanted to share some highlights of what the survey found. To really just dive into it very quickly, 15% indicated that intraoperative probes didn't undergo high-level disinfection sterilization, even though they were used in the OR. Okay, 41 to 67% of probes used in percutaneous procedures didn't undergo HLD. Now, but again, keep in mind, it's how that probe is used. So if it's over the puncture site, there's a question mark or an issue that needs to be addressed. If it's further away from the puncture site, then you know that could definitely be discussed. In addition to that, practice scans on non-intact skin showed 45%, even on non-intact skin, they just wiped it down with a disinfectant wipe, which is also incorrect. And for our endocavity, I mean, we're not that bad. We found 92% claim that for endocavity, they do high-level disinfection. But there's that still 8% that's, I don't know where they are or where they live, but they haven't gotten the message that you can't do that. In addition to that, they did look at sterile gel use or just gel use in general. And from an intraoperative standing point, 96% indicated they used sterile gel. For other sterilized procedure outside of peri-op, 30% indicated their facility used non-sterile gel. So even though there are multiple studies to show that gel has been implicated in outbreaks, there is still that issue. And actually recently, I also had an opportunity to discuss with the facility what they use, and again, depends on the department. Radiology uses single sterile doses of ultrasound gel. Go to another department, ED, you have a bottle of ultrasound gel, all gunky and gluey, and there is no tip cover anyway. It's like, come on, at least put a tip cover. So, you know, it just varies. It is amazing. And they're only literally a couple feet apart from department to department. So with that, with all these lovely challenges, we want to provide some practical solutions. Obviously, developing policies and practices that revolve around patient safety, guided in evidence, would be the way to go. We understand it's a very complex set of issues, not only for IPs, but for the actual department that owns the probes. Go figure. One of my pet peeves is if I go to a department, whether it's radiology, sterile processing, if I am telling them what their standard says, there is a big problem here. They should know their standards more than I know. So it's a big, alert, alert, alert. But again, the toolkit that was developed was designed to address many of these issues and try to assist in locating, surveying, risk assessing, and developing a policy that would fit within your organization. So with that, I will hand it off to Amy.